Hi, everybody, and welcome to this session of WSC TV. We have the privilege of discussing with two of our PIs here who just presented in the plenary session. My name is Michelle Johansen. I'm from Johns Hopkins, and I'm joined by Mira Katan from Switzerland. So hi, Mira. Thanks for doing this with me.
Thank you very much. A pleasure.
So we're going to go ahead and start by talking to one of our PIs first. This is Dr. Yasuhiro Nishiyama from Japan, and he said it was okay if I referred to him as Yasu. And you're going to tell us a little bit about the results of your study that you just presented called the STABLED study. So can you tell us a little bit about that?
Yes, so I'm honored to talk about the STABLE study. So investigating whether catheter ablation can prevent recurrent stroke in patients with atrial fibrillation. Because our purpose is to evaluate the efficacy and safety of catheter ablation plus standard therapy compared to standard therapy alone in patients, atrial fibrillation patients with recent ischemic stroke. Because usually cardiologists want to do catheter ablation for AF patients because catheter ablation can reduce recurrent stroke or reduce the mortality rate. But according to the meta-analysis or propensity score match data, it's kind of promising. But there is lack of evidence from randomized controlled trial. So that's why we motivated the STABLE trial. Mm-hmm. And then finally finished. And then today, I was presenting those data. I was really happy to that.
Wonderful. We were happy to hear. So maybe you can tell us what were the results also of your trial and what might be the impact of these results.
Yeah, so surprisingly, there was no significant difference between the groups. Groups means standard therapy, medical therapy used as anticoagulants alone versus medical user therapy plus catheter ablation. So catheter ablation itself is not working for improving patients' outcome. So that's surprising. Mm-hmm. We didn't expect that before starting the RCT.
Yeah, well, I think it's a really important topic. You know, as stroke neurologists, sometimes we think about catheter ablation simply as taking away atrial fibrillation, but we really applaud you for thinking about stroke in your composite outcome. And you did have a composite outcome, and you randomized patients to either standard therapy or standard therapy plus catheter ablation, and then followed them for about 72 months for this composite outcome. And we were also discussing before we started recording about some of the limitations and thinking through getting people into your study, and you made the interesting note of how the people who underwent catheter ablation actually felt better, and so they were less likely to proceed completely through the study. Could you tell us a little bit more about that?
Yes, so thank you for your question. So before starting this RCT, so we planned how to enroll the patients, and but one patient occurred stroke. So I talked to the patients about could you enroll this study, because ablation is not we don't know ablation is working for preventing stroke. Mm-hmm. But patients, most of patients don't want to enroll because I want to enroll. I want to do catheter ablation because many journals or many reports. Yeah, so according to many reports, ablation can reduce mortality, can reduce stroke recurrence. So we cannot negotiate to enroll the patients. So that's why. So first, almost half a year, 6 months, almost never patients.
Yeah, so it was
Yeah.
really difficult to recruit patients
Yeah.
because they had the impression or idea that they will benefit anyway without knowing the evidence, obviously. And then it's very difficult if the opinion of patients is that it will help anyway to get them enrolled in the study. So that's the big hurdle. I can see that.
Exactly. And then so I remember that kind of the moment. So cardiologist talked about the ablation to the patients. So patients really want to receive the undergoing the catheter ablation because so cardiologists really want to do ablation and really want the patient to do better outcome. So we cannot say, neurologists cannot say about that.
But now we have some additional evidence that it might be not as simple.
Exactly. So
And we
finally,
should
yeah.
look into that more deeply. And we were discussing beforehand as well that there was also an issue of crossover, which might have also to a certain degree affected results in the intention to treat analysis, I guess. So maybe you can say
Exactly.
something
So
about the crossover.
Once patient agree with the kind of medical treatment, but after that, some patients really want to do the ablation. So that's kind of crossover. So we paying attention. We are paying attention to this crossover. Want to avoid, but so it was very difficult to do that. So just 14%. The ratio was 14%. For crossover rate.
Which, in thinking about studies that are similar to that, that's actually not that high of a percentage rate. So you, in your analysis, both did intention to treat and per protocol, and didn't find differences. But we were also discussing how novel it is and how important it is that you followed people for such a long period of time, and that there's probably going to continue to be data that's going to come out from your study, which we're going to look forward to, and how maybe a piece of that is going to be the number of people for whom ablation was effective, meaning they maintained sinus rhythm, versus those people who were ablated but went back into atrial fibrillation. Because it may be that you didn't detect a difference because the group who was ablated, maybe a higher percentage than anticipated, went back into atrial fibrillation versus stayed in sinus rhythm. So there's going to be some more data coming out about follow-up for your participants.
Thank you. So your questions, very, very important question. So after I presenting and I checked the data, so almost 80% was keeping the sinus rhythm. Only just 20% was kind of the sometimes back to the AF and back to the normal because so procedure of ablation. So but almost 80% can keep the sinus rhythm. It might be good for this study.
Yeah. So, Mira, I'm sure that you agree in thinking about, prevention of stroke moving forward, right? Secondary prevention of stroke. This is a common clinical questions that we have to deal with, right? Is our patient in AF now? Is our patient going to go back into atrial fibrillation? Monitoring questions, things that we try to do to patients after stroke to prevent future stroke. We're continuing to expand our toolbox, but still as neurologists, cardiologists, we have to follow these patients. That's why it's so important to get them into studies like yours. So thank you so much for doing that. I'm sure maybe we'll circle back. Is there anything else that you'd like to add?
And so what I want to say is one thing I want to say is that so before starting RCT, we calculated 13% as expected rate. But so in fact, only 5% was the rate. Rate means primary endpoint. So it's kind of, we saw the big gap between the before starting and after finishing. So, but in this study, the key point is that collaboration, strong, intensive collaboration between cardiologists and neurologists. So both of us are watching patients, only one patient, the same patient, from the beginning to the end. So that's why simply it is catheter ablation is not the solution to improve outcome. So collaboration is very, very good point, I think, so in my challenging opinion.
Thank you very much. So I think we go on into the topic. So we covered some interesting data concerning cardioembolic stroke and secondary prevention in those patients with AF. But now the question is, and of course secondary prevention is a huge field and evolving, and we were really also interested to hear Mike Sharma's presentation today in the plenary session. Mike Sharma is a neurologist from Canada, a very prominent one, and he was the PI, or is the PI, of the Oceanic trial, looking at non-cardioembolic stroke and what we can do for those patients, what is in the toolbox for those patients. And he presented data on a new compound, and he will probably summarize a bit the idea behind Oceanic and what that could have impact for us all to our toolbox.
Thanks so much, Mira. Pleasure to be with you today. So, you know, the real drive behind this came from what we saw in the COMPASS trial, where we used low-dose rivaroxaban plus aspirin. And we saw a decrease in the risk of stroke compared to aspirin of about 50%. That was a hazard ratio of 0.5. We really wanted to get an agent that was safer than rivaroxaban. Rivaroxaban was associated in COMPASS with GI bleeding. And then we started to look at factor XI inhibitors. Now, the genetic epidemiology suggests that if you're born with deficient factor XI levels, you have a very low risk of stroke and as well DVT. And that occurs in spite of no real severe risk of significant spontaneous hemorrhage and no increase in the risk of ICH. And the reason for that has to do with the biology of factor XI. You know, the more I look at the coagulation cascade, the little eddies and branches, the more confused I get. But, you know, when we simplify it, when we think about how we understand it, factor XI, the reason there's a potential to differentiate an effect on hemostasis from pathologic thrombi is that the activity of factor XI depends very much on the mechanism by which thrombosis is triggered. In hemostasis, there's a defect in the vessel wall. A lot of tissue factor, which is mostly outside the vessel, is exposed to the blood, activates factor VII, factor X, thrombin is generated, and then factor XI is a little feedback loop from thrombin. When there are large, massive amounts of tissue factor, that feedback loop is relatively unimportant. On the other hand, if you have a thrombus which is confined to the vessel, a pathologic thrombus, that is generated by relatively small amounts of tissue factor. The inside of blood vessels doesn't contain a lot. Then that feedback loop is proportionally much more important. So big driver of pathologic thrombi, small driver of hemostasis. We've seen this in animal models as well. The genetic epidemiology, Mendelian randomization studies all suggest higher the factor XI levels, greater your risk of ischemic stroke, and with lower factor XI levels, fewer strokes, and no real significant spontaneous hemorrhages.
So you actually have the good stuff without having the side effects, more or less.
Yes, having your cake and eating it too.
So you were presenting today the baseline characteristics of one of the largest secondary preventive trials in non-cardioembolic stroke patients.
Yeah.
So maybe you can say a bit about the efforts and you know, it's amazing that you were able to recruit all these patients in so many countries over a not too long time frame. So maybe you can say a bit about that.
Well, absolutely. So, you know, we've had great success in cardioembolic stroke with factor X inhibitors, decreased significantly the risk of stroke. Non-cardioembolic stroke, we're really stuck with aspirin. So I think part of the reason for our success is there's a real unmet need, a real desire for something better, especially over the long term. So in Oceanic Stroke, we aimed for a total recruitment of 12,300. We overshot that slightly. There are 12,327 participants in the trial. We recruited from over 700 centers in 37 countries, so really
Wow.
a global trial. we set up a committee to increase diversity. So we were particularly interested in women and other groups which are underrepresented in clinical trials. And I can tell you, in spite of a lot of efforts, we developed a toolbox, trained sites in doing it. The proportion of women we got was 33%, exactly a third. Now, our estimate of what the epidemiology would suggest for women with our population characteristics is about 40%. So we were under that, and we actually presented this morning a study on reasons why women may not participate much, and we'd like to explore that further. You know, to get into oceanic stroke, you had to be an adult, over 18. We set no upper age limit. What the research has shown is when you set an upper age limit, you recruit fewer women, because women tend to have strokes at a later age.
At a later age, yeah.
So we did that purposely in the design of the study. To get in, you had to have either an ischemic stroke with an NIH up to 15, high-risk TIA, ABCD2 of 6 or 7, and one of three things: a history of atherosclerosis, which could be coronary artery disease and MI in the past, or asymptomatic stenosis. The stenosis did not have to be causative or even ipsilateral to the index event, just had to be present. You could have atherosclerotic plaque on imaging, again, not causative anywhere, and had to just intrude into the lumen. Or you could have a non-lacunar infarct. Either of those three pathways got you in. We got a very good mix of stroke subtypes, 43% large artery athero, 30% unknown cryptogenic type, and 22% small vessel disease. So we think the results will be widely applicable.
So I actually had a question about that. So when I was listening to your presentation, you did a great job describing sort of the study characteristics, but I was quite taken aback by the fact that you had 30% of stroke of unknown etiology. What do you think about that? I mean, granted, you excluded or tried to exclude cardioembolic stroke.
Yeah.
But why do you think there was such a high proportion of stroke of unknown etiology?
So, you know, one of the entry pathways was non-lacunar infarct. So I think we captured some with that. You have to remember that in toast unknown etiology, you can have multiple competing things that you don't know are there. I can share with you that we invited investigators and sites to adjust the toast subgrouping depending on the results of investigations. So about 2% ended up, after they were in the trial, being cardioembolic, but not higher than that. Now again, this was standard clinical follow-up. There weren't implanted loops. None of that was part of our trial. We didn't prohibit it, so if you wanted to do that, you could. But I think, you know, the reason for that proportion is we specifically allowed it. Our exploration of the phase 2 data, and certainly as well in COMPASS, suggested that you would have a high impact on that stroke subtype as well. The one that we were suspicious might not have as high an effect as small vessel disease. It's important to include it, and we may well see the same effect in that subgroup as we do in the main trial.
So I guess that's also why you had the prerequisite of having some atherosclerotic disease present. So actually what might be also the triggering factor, not having a symptomatic stenosis per se, but have a high vascular burden overall.
That's exactly it. You know, one of the reasons to choose that, and certainly we learned this in COMPASS, even if it wasn't causative, it picked out a group of people who had a high risk of stroke. And I think aside from what the inclusion-exclusion criteria say, to my mind, what's more important is what's in Table 1, the baseline characteristics. That's really who the trial results apply to.
Wonderful. I think we're really very excited
I
to
know.
hear the
is there
final
any results that you can pass along early on?
I would be happy to. I'm blinded, and we haven't yet locked the data set. But I can tell you that we will achieve database lock before the end of the year. So very shortly, we'll all know.
So maybe we hear some results the beginning of next year then?
Entirely possible.
Sounds good. Sounds great. So we are looking forward to that, because it might be that if the results are positive, we indeed do have a new kid on the block in our toolbox to prevent stroke in patients with non-cardioembolic strokes, or not known cardioembolic stroke at the time of the incident stroke.
Correct.
Wonderful. anything to add from your side also, Michelle? Do you want to?
Maybe just, could you close by talking a little bit about your study design? You guys were very creative and yet very well done in thinking about a drug trial across multiple different stroke subtypes, your enrolling time frame, et cetera, your duration of follow-up. Will you describe that for the audience?
Thanks so much. So, patients were randomized within 72 hours of symptom onset to either 50 milligrams of asundexian or matching placebo. It was event-driven, minimum duration of treatment of 3 months, and we estimate about 31 months on average would be the treatment duration. The three categories, a history of atherosclerosis, visible plaque on imaging, and non-lacunar infarct, those three things were designed to pick this population who would have a recurrence rate high enough to make it worthwhile enrolling in the trial, worthwhile treating, and yet be representative of the population that we treat. One of the issues that we deal with in prevention trials with antithrombotics is to avoid the trial becoming lacunarized. So lacunes with small deficits are easy to recruit into trials, and they may not, certainly after SPS3, they may not respond well to more aggressive antithrombotic therapy. So this design enabled us to get the representative population with subtypes that were responsive, not ignore small vessel disease, and yet end up with something that would be easy to apply in the real world. The other option you have as a trialist is to try to cap the proportion of lacunes, which is complicated to do, hard to do in real times, and added burden for sites, and we avoided that in our trial.
And maybe on a last note, so the idea of factor 11 obviously is looked at in Oceanic, but we have another large trial ongoing, the Librexia trial, looking at the same mode of action in a bit different design, so they have a little bit different in- and exclusion criteria, but that will add to the evidence concerning factor 11, so we will have even more information going down the road, so that's going to be really very interesting.
It's really great to see that additional trial, Librexia with milvexian. Milvexian at phase 2 also showed a signal of effect. I think for us in the stroke community, it is wonderful to have two large trials of this type going into a new therapeutic area.
And hopefully we can then also look at the pooled data at some point, so then we really have also certainly enough, evidence and power to see even and look even into subgroups as well, and have even more information about those patients who might benefit most within those who have been enrolled into the study.
The combined data set will be 27,000 participants, so a lot of data, a lot of subgroups we can examine. So
a lot ahead of us. I'd like to conclude here, and thank you very much, both of you, of presenting interesting data to the WS Stroke Conference, World Stroke Conference, and hopefully see you also next year, and hopefully also see you at ESOC next year. So thank you very much for listening.
Pleasure.
Thank you. Congratulations.
Thank you so much.